سؤال يا دكتور حسن قبل ما نخلص. If any of the audience have a question about tips في المحاضرة اللي فاتت ممكن يسألوا لينا أو للدكتور حسن. Okay.
Thank you, Professor Muhammad Al-Warra'i, for the nice presentation. This is a presentation about percutaneous transhepatic portal interventions. This is our portal circulation. This is the portal vein being formed by the splenic vein and the superior mesenteric vein. The inferior mesenteric vein joins the splenic vein. This is the venous collaterals related to the portal circulation, which either the esophageal varices, gastric varices, umbilical varices, and colonic varices as well. CT reconstructed images of the portal circulation, as you all can see. Right branch, left branch portal vein. So how can we access the portal vein? We can access the portal vein through an existing tip stent. Or we can do a transvenous balloon-occluded retrograde transvenous obliteration, what we call BRTO. We can go through percutaneously through the liver, transhepatic, or percutaneously through the spleen, a transsplenic approach. So these are the four approaches to access the portal circulation. Transsplenic and transhepatic approaches. In a transhepatic approach, in cases of post-splenectomy, or target lesion involving the main portal vein, then we use the transhepatic approach. For the transsplenic approach, we use it in cases of liver transplant or procedures performed under local anesthesia under ultrasound and fluoroscopic guidance, percutaneous puncture of the perihilar splenic venous branch or intrahepatic portal vein branch. At the end of the procedure, the hepatic and splenic tracts are embolized. So we are talking today about the transhepatic interventional procedures. You can either do a reverse tips in Budd-Chiari syndrome. You can do transhepatic variceal embolizations, portal vein stenosis and treatment, either a post-transplant or post-traumatic stenosis, portal vein embolization prior to liver resections. So this is the reverse tips. First of all, we percutaneous puncture of the portal vein, and then within a straight line, the Sheba needle is introduced into the hepatic vein or the IVC. Then a wire is passed and being snared by a snare introduced through the internal jugular vein, and then the procedure is standard tips after that. So this is the wire being snared into the sheath, into the neck, and then the procedure is completed as a standard tips. But the starting part of this procedure is reverse tips. So this is after being snaring the wire, the catheter is passed through the sheath into the portal vein, and then the procedure continues. This is the stent being deployed between the portal vein and the IVC. So this is a reverse tips, and sometimes we coil our tract. This is a coil being introduced in the tract. Sometimes we don't coil the tract. Treatment of abdominal varices through transhepatic portal approach. The varices are usually esophageal or gastric varices, duodenal varices, rectal varices, and also there are ectopic varices like a peristomal varices. So patient has got portal hypertension, and then he undergoes colectomy for any reason. Then a stoma is being surgically created in this patient, and sometimes we get peristomal varices. So this is a case of a patient who had right-sided stoma. You can see the colectomy and right-sided stoma, and you can see in the CT there is peristomal varices, so varices in the subcutaneous tissue around the stoma, the colonic stoma. So we go transhepatic, and then through the transhepatic into the portal vein into the SMV, the superior mesenteric vein. This is contrast being injected, and you can see the varices. And if you look closely, you can see the ring of the stoma. I don't think if it is. You can see the ring of the stoma here more evident. This is the ring of the stoma on the skin of the patient. So coil this lesion, and the images are being swapped. This is the at the time of coiling, and this is after completion of coiling, and you can't see the varices anymore. Another case with left-sided stoma, and again you can see the peristomal subcutaneous varices on the left side now. So on the left side, this means that we'll have to go through the inferior mesenteric vein rather than the superior mesenteric vein. So again, percutaneously through the liver into the portal vein, and then cannulate until we reach the inferior mesenteric vein, microcatheter. This is the peristomal varices. You can see the peristomal varices here, and then glue histoacryl is used. This is the histoacryl, and the peristomal varices are occluded. A third case, this is a very challenging case. This is a young lady, 28 years old. She had a surgical, a bariatric surgery called VBG, vertical band gastroplasty, and she present with a distended abdomen and tense ascites. I was asked to tap this ascites. The ascites came out as bile, so she had, which means that she had some bile injury during this surgery. You can see here, these are the metal clips of the surgery, very close to the porta hepatis. This was thought to have caused biliary injury. I did PTD and put a biliary drain for her. The ascites was relieved, and then a week later presented again with ascites. This is after being this is the second attack of ascites. Aspirated this ascites, clear ascites, went back through the images, reconstructed the images. One of the surgical clips is pinching the portal vein itself at the porta hepatis. So this is ascites due to portal hypertension rather than the previous ascites, which was due to direct biliary injury. So during this surgery, the surgeon caused direct biliary injury, causing biliary leakage, and portal vein injury as well. And you can see here the portal vein and very narrowed at the site of the metal clip. So I went into the portal vein. You can see very tight stenosis in the portal vein here. This is the catheter being past the stenosis in the portal vein into the SMV, and balloon this stenosis and put a melted stent into the junction between the SMV and the portal vein. This is the result. This is the plastic stent from the biliary plastic stent. This is the metallic portal stent, and these are the clips of the surgery, and you can see them very close to the portal vein and the bile duct. This lady is been on follow-up now for almost 8 years with without any complications so far. The last topic is portal vein embolization pre-transplant. So you want to increase the volume of the portal of the liver segment. So this is a technique used before liver resection to increase the size of the liver segment that will remain in the body after surgery, in the patient after surgery. It redirects the portal blood to the segments of the future liver remnant, resulting in its hypertrophy. Portal vein embolization is indicated when the remaining liver's volume is too small, so we want to increase it. Two absolute contraindications for portal vein embolization are extensive ipsilateral tumor thrombus and clinically evident portal hypertension. Portal vein embolization also can be performed using transhepatic ipsilateral or contralateral approaches. So either we go through the right lobe to embolize the right portal vein, or the right lobe to embolize the left portal vein, and vice versa. A variety of embolic agents can be used. Glue, alcohol microparticles. We usually use glue. In normal livers, sufficient hypertrophy typically occurs within 2 to 4 weeks after embolization, whereas regeneration in patients with cirrhosis can take up to more than 4 weeks. So this is the portal vein angiogram. We are going from the right side, and then we've embolized and the right side. You can see the hypertrophy of the left lobe. In conclusion, interventional radiology offers minimally invasive techniques that can manage portal circulation situations which are surgically and endoscopically challenging. Thank you very much.
Thank you, Doctor. Thank you, Dr. Hassan, for this nice presentation. Any question?
يعني أنا بشكر صديقي العزيز الأستاذ دكتور حسن for the creative presentation, and I think we have 5 minutes to discuss some issues. And you know with me that TIPS is one of the most intelligent portal decompressive operation ever seen. حقيقة دايما نقول إن البورتال decompressive operation زي الوارن وزي اللاين رينال شانس إلى حد كبير ما بقوش يتعملوا، لكن التيبس ستيل إلى الآن بتتعمل كديكمبريسيف اوبريشن للفاريسز وللاسايتس علشان هي ستنت جوه البورتال فين. انا بحييك طبعا على التنوع بتاع البورتال سيركوليشن كالعاده. And my question is how much time you face stent thrombosis and how can you deal مع thrombosis أو مع tips dysfunction.
ثانك يو بروفيسور ورايف. طبعا لا يفتى ومالك في المدينه، بس يعني هو في تو تايبس اوف بورتال ستنتس هنا. في بورتال ستنت اللي هي التيب ستنت، وفي بورتال ستنت اللي حطيناها في البيشنت ودي entirely portal vein stent يعني.
I mean tips.
دي الست دي لغايه دلوقتي دي حاجات ما بنعملهاش كتير طبعا، انها تبقى بورتال فين ستينوزز ونحط لها ستنت، بس الست دي لغايه دلوقتي almost 9 years الستنت بيتنت. التيبس ستنت بقى للاسف بنشوف الحالات دي كتير، ونشوف ان اللي يحصل فيها ثرومبوزس كتير، بنضطر نحط ستنت جوه ستنت. وفي عيان حصل له مثلا في ال7 8 سنين 2 events of thrombosis، فدلوقتي في 3 4 ستنتس جواه يعني.
عشان الهايبر كواجلابيلتي طبعا
بالزبط.
بتاع يعني مش الستنت.
البنت الست الثانيه دي عشان هي نورمال ليفر اصلا، فالستنت بقى لها 7 8 9 سنين كويسه.
لكن السؤال الثاني في البورتال فين امبولايزيشن and how much time you wait and نسبة العيانين بالتقريب اللي هم عندهم انجري في الليفر، مش النورمال ليفر. يعني في النورمال ليفر انا اجري مع حضرتك ان هو almost كل العيانين الليفر بتاعهم بيكبر، لكن العيان اللي هو في انجري من سي، انجري من هيباتيتس، انجري من سي، او انجري من فاتي انفلتريشن، او في ايرلي سيروزس، اوف كورس مش كل العيانين الليفر بتاعهم بيكبر. فيعني how much percentage يعني انت العيانين دول؟
احنا الاكسبيرينس عندنا مش كتيره في اسكندريه، عشان احنا الزرع الريسكشنز والزرع عندنا مش كتير قوي يعني زي القاهره، بس اتليست بيبقى شهرين في الناس اللي عندهم سيروز والناس دول، اتليست بيبقى شهرين. بس احنا ما اديش رقم كبير لان الحالات مش كتيره قوي، عشان كده مش قادر ادي رقم.
يمكن انا اجي مع حضرتك برضه، لكن احنا عندنا برضه ستادي كان في اللي عملنا البورتال فين امبولايزيشن في الانجرد ليفر، فكان حوالي 70% من الانجرد ليفر دول الليفر بتاعهم بيكبر. و30 الليفر بتاعهم ما بيكبرش to the level of surgery. يعني 70 الليفر بيكبر ويعمل ريسكشن، 30 ما بيكبر بس ما بيوصلش ليفر سيرجري. لكن اللي كان ملفت انه الاتش اس سي بتاعتهم بتقل، فكان قفله البورتال مع الهيباتيك انا اي ثينك انها تفتح ايرا جديده في المانجمنت بتاع الاتش سي. يعني انت هتعمل له بورتال بنيه انه يعمل ريسكشن، ممكن ما يعملش ريسكشن لكن البنفيت هتكون اعظم من انك امبولايزيشن alone. Any question from the audience? Okay.
We'll move to the next talk, which by Dr. Attila Kozak. It's about what is electrochemotherapy and its role